A 30-year-old nulli parris woman comes to the office for evaluation of infertility. The patient has seen attempting to conceive for the past 2 years. Menarche was at age 11, and her menstrual cycles occur 2 to 3 times per year and last 7 to 10 days. The patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 122 per 84 mm mercury and pulse is 84 per minute. BMI is 35 kg per meter square. Physical examination shows mild acne and hair growth on the upper lip and chin. The question is, this patient is at greatest risk for which of the following complications? Your options are A. Adrenal atrophy, B. Chronic pelvic pain, C. Cushing syndrome, D. Diabetes mellitus, type 1, E. Endometrial carcinoma, F. Vaginal intraepithelial neoplasia. Type your answer in the comment box. Congratulations if your answer is E, which is endometrial carcinoma. This patient with oligomenorrhea, signs of hyperandrogenism, example acne, and hirsutism, and infertility likely has polycystic ovary syndrome. Polycystic ovary syndrome is characterized by increased ovarian androgen production, which acts on the hypothalamic pituitary ovarian axis to cause an abnormally elevated LH to FSH ratio that inhibits ovulation. Therefore, a common presentation is irregular menses with anovulatory infertility. Obesity, which is common with polycystic ovary syndrome, can also contribute to the anovulatory state by inducing hyperinsulinism, which acts synergistically in the ovary with LH to upregulate androgen production. In addition to increased androgen levels, polycystic ovary syndrome causes increased estrogen levels due to androgen to estrogen conversion by the enzyme aromatase within the ovary, example estradiol, and adipose tissue, example estrone. Estrogen normally stimulates endometrial proliferation to allow for implantation. Progesterone, which is released after ovulation, opposes endometrial proliferation by inducing cellular differentiation, protecting against endometrial hyperplasia. Women with polycystic ovary syndrome have disproportionately high estrogen production but low progesterone release, that is unopposed estrogen exposure, due to chronic anovulation, resulting in unregulated, increasingly disordered endometrial proliferation, and increased risk for endometrial hyperplasia and carcinoma. If you chose any option other than E, you were incorrect. Let's briefly discuss the other options. Choice A. Adrenal atrophy presents with severe fatigue, weight loss, and low blood pressure due to glucocorticoid and mineralocorticoid deficiency. In contrast to polycystic ovary syndrome, which is associated with hirsutism, women may experience axillary and pubic hair loss due to adrenal androgen deficiency. Choice B. Various disorders, example endometriosis, pelvic inflammatory disease, can cause chronic pelvic pain by inducing pelvic inflammation and tissue fibrosis. However, polycystic ovary syndrome does not typically cause pelvic inflammation or pain. Choice C. Patients with Cushing syndrome have symptoms similar to those of patients with polycystic ovary syndrome such as obesity, menstrual irregularities, and increased body hair. However, additional findings such as hypertension, abdominal striae, and supraclavicular fat pads are also typically seen due to the excess cortisol. Choice D. Having another autoimmune disease, example Hashimoto thyroiditis, increases the risk of type 1 diabetes mellitus. Although polycystic ovary syndrome is a risk factor for type 2 diabetes mellitus due to increased insulin resistance, it is not associated with type 1 diabetes mellitus. Choice F. The primary risk factor for vaginal intraepithelial neoplasia is persistent human papillomavirus infection. If you're finding this difficult to understand, consider watching this episode again.